So how we can define stroke and the penumbra? So in case of penumbra, you have delay or increase in Tmax or mean transient time, while the cerebral blood volume, either it's increase or it's normal. While the infarcted tissue, the mean transient time increase, while the cerebral blood volume decrease. Using these parameters and giving them to artificial intelligence software to analyze them and giving us a map for the stroke. So as you can appreciate here in this image, this is the CT and this is the CT perfusion. And this is CTA. So using these three images, using the CT perfusion or the cerebral blood flow definition of less than 30% compared to normal tissue, this will define to us the core. While using the Tmax, and at the same time, it's the mean transient time to identify the penumbra. By subtracting the infarcted tissue from the whole picture, including the penumbra, we can reach how much salvageable tissue we have. So this concept was taken by the Extend team, and they tried to figure out whether altiplase, if we give it beyond 4.5 hours, is effective or not. And actually they reach that, they conclude that altiplase outcome was favorable in comparison to placebo. And as you can appreciate here, the NIH score, the MRS score is shifted to better outcome with altiplase group, as you can appreciate it here. Then a meta-analysis of the Extend study and previous two neutral studies, which is ECAS4 and EPIFET, found the same result, that there is a good outcome, but at the same time we have increase in the symptomatic intracranial pressure. This study with the meta-analysis conclude that altiplase achieved better functional outcome than did patients who received altiplase beyond 4.5 hours until 9 hours achieved better outcome than patients given placebo. And the rate of symptomatic ICH was higher with altiplase, but this increase did not negate the overall benefit of thrombolysis. And this actually, the finding of this trial and meta-analysis lead to change in the guidelines, specifically the Australian guidelines, and we have now strong recommendation in Australian guidelines, stroke guidelines, to give patients altiplase beyond the 4.5 hours, and this is our daily practice. And even the European Stroke Organization guidelines have supported this recommendation, but still it's not there in the American Stroke Association guideline. Now we end with altiplase, and since 1995 we have just one gun, which is altiplase. So why we don't have another machine gun, which is in this case tenecteplase? So why tenecteplase? Tenecteplase is more fibrin, more high fibrin specific, and it has longer half-life and with a fewer side effect. And these data actually came from the cardiology trials. Most of the cardiologists now using for the myocardial infarction tenecteplase rather than altiplase. So to start with stroke trials, the first study was NORTEST-1 trial, which is it's done in Norway. So they give a 0.4 milligram per kg with a maximum dose of 40 milligram TNK versus altiplase, but in patients with mild stroke. So, and the result of the study showed that it's not superior, but it's well tolerated and it's non-inferior. So that's why you can find in the American Heart Association a weak recommendation to use tenecteplase in mild stroke. The same Norwegian study, which is NORTEST-2 study, tried to study tenecteplase effectiveness in patients with moderate strokes with NH score more than 6. But actually, this study was terminated earlier because of increase in the intracranial pressure and intracranial hemorrhage. A Canadian study, which is active trial study, compared 0.25, which is the smaller dose of tenecteplase, to altiplase 0.9. And they found that tenecteplase is not inferior to TPA. It's like TPA. There was no significant difference in the outcome and even the ICH or death within 19 days. The newest trial, which is done actually in Melbourne, in Australia, which is the Test A trial. And in this trial, they use what they call it a mobile stroke unit. So you have a stroke unit, which is mobile, moved to the patient. So you have an ambulance contains CT and sometimes CT and CTA. So at the scene, you will do the image, and then you will give the patient the medications. So this trial, they found that the patients given tenecteplase, the volume of reperfusion will be smaller. So this means tenecteplase is more effective. Lastly, during the last World Stroke Organization in Toronto, 2023, this is a preliminary result of the Test 2 trial. Still, the trial not published in journals, actually, in peer-reviewed journal, but this is just from the World Stroke Organization meeting. The preliminary result of this study, which compared TNK 0.25 to alteplase, show the same result of ACT, and we know that from this trial that the recommendation favor tenecteplase as a standard of management for AV thrombolysis. We have already those patients, those group of patients with stroke with large vessel occlusion. Why we don't try tenecteplase with them rather than alteplase? And actually, we have a study published, just recently published, I think 1 or 2 years back, which is Extend 1A TNK, led by Bruce Campbell. This study. They tried to study TNK compared 0.25 to alteplase, and the outcome was the achievement of reperfusion. And actually, reperfusion, as you can appreciate here, achieved with tenecteplase group in 22%. So it's double than the alteplase group, which was 10%. They tried to compare the 0.25, which is the small dose, with the high dose, and they found that there is no big difference, while there is increasing complication with high dose. After this study, actually, the American guidelines and all the guidelines, including Australian, New Zealand guidelines, changed to that in that the tenecteplase is the recommended drug in case you have a patient with large vessel occlusion presented within the window. So you give tenecteplase and shift the patient for thrombectomy. So take home message 1, advanced neuroimage in stroke helps expand the therapeutic window and overcome time restriction for intravenous thrombolysis in acute ischemic stroke. Tenecteplase in a dose of 0.25 milligram per kg is an effective alternative to alteplase 0.9 milligram per kg for intravenous thrombolysis in acute ischemic stroke with a proven efficacy and safety. 3, tenecteplase has an advantage over alteplase in terms of ease of administration and medication, because with tenecteplase, there is no need for the maintenance dose. So you don't need to give a bolus dose and the infusion dose, because in tenecteplase is just a 1 dose. You just count with it within 10 seconds and you push it like that. Intravenous tenecteplase may be better than alteplase in patients with large vessel occlusion. The second chapter of this talk will be about the current advance in endovascular treatments. So we know that in 2014, there was the publication or the release of the results of what we call them the big 5 studies of thrombectomy, which were Mr. Clean, Escape, Extend, Swift Prime, and Revascat. These studies involve or include patients with the following features. First of all, disabling stroke. Second, NH score of 6 and more. Pre-admission modified Rankin score of less than 3. There is no evidence of hemorrhage in CT, and aspect score more than and equal to 6, and there is a large vessel occlusion. And the result of this study actually showed that the number need to treat is between 2 to 3. So you treat 2 to 3 patients to have a good outcome While if you remember, in thrombolysis alone, even within the first 90 minutes, you need to treat 4 to 5 patients to have good outcome, one outcome. Then in 2018, the also, let's say, pillar studies in the thrombectomy released, which were DAWN study and Diffuse 3 study. And these studies extend the window of thrombectomy from 6 hours to 24 hours. So this is just like, I don't want to go in details of these studies, just to refresh your memory. So in DAWN study, the thrombectomy group achieved independent outcome in approximately 50% versus the standard care, which they achieved 30%. And as you can appreciate here, that there is a great shift to better outcome in thrombectomy in comparable to control group. And in Diffuse 3, also approximately the same result, 45% versus 17%. And as you can appreciate here, there is a great shift to better outcome in the thrombectomy group. A meta-analysis of these studies, which is well-known, Aurora meta-analysis, show that the effectiveness of thrombectomy from 6 to 24 hours is valuable. That's why we have it now in the guideline clearly. If the patient, in selected patients with beyond 6 to 24 hours, between 6 to 24 hours, we shall include them in thrombectomy. So as you saw previously, these studies include only those patients with the aspect score 6 and above. So it means that it's not a large core stroke. So what about large stroke or large core stroke? Actually, it's still not this question is still not answered. But I will just give you the studies published in this to answer this question. It started with the Japanese. Rescue Japan in 2022, and as you can see or appreciate, as you can see here, that there is a better outcome, but there is increase in the symptomatic hemorrhage. The second study is Angel Aspect study, which is a Chinese study, and the investigator conclude that patients with large cerebral infarction had a better outcome with endovascular therapy administered within 24 hours than the medical management alone, but had more intracranial hemorrhage. The third study, which was a multi-center study, which is SELECT-2 study, published in 2023, they found that endovascular thrombectomy resulted in better functional outcome, than medical care, but was associated with vascular complications, cerebral hemorrhage, but the cerebral hemorrhage were infrequent in both groups. A systematic review of and meta-analysis of all these studies conclude that there is a low certainty evidence show that there is possible a large increase in functional independence, a small non-significant decrease in mortality, and a small non-significant increase in symptomatic ICH among acute ischemic stroke patients with large core or large infarction undergoing thrombectomy compared to medical treatment alone. So in our practice, actually, what we are doing in our hospital, so if the core is equal or less than 70 ml, all those patients, we include them for thrombectomy. If the core is more than 70 ml, then it's a matter of discussion between the neurologist on call and the interventionist on call. We usually include those patients below 60 years of age and without comorbidities. Recently, also published or the result released during the World Stroke Organization just 2 months ago, the tension trial, and in this study they just used the CT alone to randomize patients. So they randomized patients with aspect score 3 to 5, which means moderate core, either to thrombectomy or to best medical treatment. And the study result show that thrombectomy was associated with improved functional outcome and lower mortality in patients with acute ischemic stroke from large vessel occlusion with established large infarction in the setting using non-contrast CT as predominant image modality for patient selection. So still,